welcome to today's teaching session. Thank you for joining us over your lunch. If you would like to keep your cameras on so we can see your smiling faces and sort of gauge interest or looks of intrigue or questioning, then that'd be lovely. But equally, if you're eating your lunch, which I think many of you may well be, then that's also fine. We do appreciate it all the time of the day. Nice to see everybody. My name's James Waldron. I'm a GP working in Nottingham. I'm an associate with the Nottinghamshire Alliance Training Hub, very much a portfolio GP. It gives me great pleasure to introduce to you Jenny Barnes today. Who's going to be talking about a very, very important but tricky topic of perinatal health. Very, very important and often not treated as well or addressed as well as we could. So I think really great topic to be looking at today. If you would like to ask any questions on the way through, please pop your hand up if you would like to ask it. If it's a complicated one and you want to sort of join in, or you can pop it in the chat. I'll be keeping an eye on that and come to Jenny bit by bit. Just to let you know, so the Training Hub does absolutely loads of events. We've got dermatology coming up on the 16th of April. Still a few spots available for that, and we've got a 33% off at the moment, so it's only £30 for that entire day of dermatology teaching. Please sign up or share it around. We have lots and lots of other bits and pieces coming up too, including we're looking to do a sort of an obstetrics, perinatal and pediatrics day in the near future too, so keep your eyes peeled for that. Denise is going to put some links in the chat there for you to have a little look at. Okay, well, without further ado, you didn't come here to listen to me today, so I'll hand over to Jenny, who will introduce herself, and we'll get cracking with today's teaching. Thank you, everybody.
Brilliant. Thanks, James. And welcome, everyone. I'm Jenny Barnes. I'm talking to you today in my role as perinatal mental health champion for Nottingham and Nottinghamshire. And it's great to have a variety of roles and thank you for joining us, because I know it's difficult sort of over lunchtime to find the time. As James said, I'm very happy to, if you want to interrupt me, there's only a small group of us, so if you want to interrupt me and ask questions as we go along, absolutely fine. If you want to pop it in the chat and James will keep an eye on that, then that's absolutely fine too. So I will just share my screen. So first, let's get this working. Here you go. So if you've just to start with, just a couple of minutes, if you could just scan in and use that QR code. It's just got a couple of questions which just allows us to collate some data for NHS England. So this is a 6-month project that we've got from NHS England to provide training to primary care healthcare professionals about perinatal mental health, and we're actually coming towards the end of it at the moment, but I'll come on to a few things that are going to continue out of it. So if you could just do that, and then there's another similar question just at the end, just gauges your increase in your knowledge, hopefully, and you will then be emailed a certificate from through our training hub. So the whole project is actually run through Coventry and Warwickshire Training Hub. And I'm actually based, I work in Coventry and Warwickshire rather than in Nottingham. So I'm based in Kenilworth. I'm a GP in Kenilworth. I've been a TPD for our local training programme for the last 13 years, stopped that recently to take on this role, but I'm a GP trainer in practice as well. And perinatal mental health is a particular sort of interest of mine, having seen lots of patients with it and seen how we can significantly help women. And particularly, as James said, we're missing a lot of this and we're not treating it properly for women. And also my sisters have both been through various different journeys with it, which has led my interest into it and to increasing really an awareness of it. There are, if you want to go on further and do some more education into it, the HEE Learning for Health online learning modules are great with some more information on it if you want to follow up that in your appraisal. And I've sent Denise a copy of these slides so she can circulate them, and as James said, it's being recorded as well. So what are we going to cover today? So we're going to have a look at what perinatal mental illness is and how common it is, what are the consequences of it. So why do we need to take and make more awareness of it? What is actually preventing us from managing these women and these families effectively? And how importantly, how does it present? And how can we encourage open conversations about the area? And more importantly, then when we found these families and these women, I'm going to go through some resources, and there's some new resources locally for you help support you. And please, any questions, any feedback, or please just ask. So just to start with, a bit of a sort of disclaimer. So this sessions, some people might find traumatic, may have been through things yourself about it. So please, you can turn your camera off. If you do feel it challenging, please step away for a moment. As we go through the session, I should also say, so we will talk about mothers. We are gender inclusive, so we include all birthing mothers as part of this. But we will use the word mother. So what is perinatal mental illness? So it goes from conception to the child's first birthday, so 12 months postnatally. And it is really common. So this infographic here, it's showing 1 in 5 women suffer with PNMI, perinatal mental illness, and 1 in 10 men, which when we first started looking at this more, I was shocked about the 1 in 10 men. I probably was seeing 1 in 5 women in practice, but 1 in 10 men. And I think we're probably missing a lot more of them. And it includes a wide variety of psychiatric conditions, and we'll go through them. And the most important thing I want you to take away with is it's common, it's serious, it's missed, but we can pick it up. And it's not difficult things. There are small things that you can implement within primary care. So this graph is really just to make you think about what the incidence of depression is compared to other physical health problems that women have during the perinatal period. So how much importance do we place on diabetes, on hypertension, on hemorrhage, on preeclampsia, and how much monitoring is done of that through antenatal, postnatal care? And also it's looked at by country. So you've got the HIC as high income countries, then you've got Africa and you've got South Asia. So this is not just a high income country problem. It's actually worse in different healthcare and different populations as well compared to ours. So it's really just thinking about it. And part of this, the reason that we've got this money to do this education is look at the incidence of it. 20% in South Asia will have an episode of perinatal depression. So it's really important that we bring this level of awareness back to it. Just take you back to physiology a bit. Not in too much detail, but it's no wonder that women struggle when you think about the hormone levels that are happening. So you've got this gradual increase in estrogen and progesterone through pregnancy, through up to your 3rd trimester. You give birth, and suddenly they all start to plummet. And when we look particularly at postpartum psychosis, this is a woman's highest ever lifetime risk of developing psychosis. And when you look at what hormone levels people are developing, are struggling with, then it's no wonder, you throw in a bit of everything else in life changing, and you've got this to deal with as well. And that it kind of leads to a bit of a perfect storm of things sort of developing. Risk factors. So there's lots of them. Antenatally and postnatally. Some of them are probably all the ones that you're looking out for and thinking about. So if you look antenatally, previous mental health illnesses. So if they've had a serious mental health illness, they should be under the perinatal psychiatrists and be monitored. And so that might be something to just think about. If a lady comes to you and has previous bipolar, isn't under the mental health team, and is saying she's thinking about getting pregnant, please be proactive about it and think about it. Or if you're doing a depression review, actually, how serious is that depression? Is that woman of childbearing age? And actually, is that a discussion you need to be having at that point, rather than it becoming a bit more of a crisis a bit further down the line? One that I was more surprised about. So unintended pregnancy is a risk factor for PNMI, and the rates of unintended pregnancy are about 1/3 of pregnancies are unintended. So 1/3 of women start with a risk factor for perinatal mental illness. If you look at the postnatal risk factors, again, there's understandably there's some represented in both groups. Again, you've got the unplanned pregnancy in there. Not breastfeeding is a risk factor for postnatal mental illness, and it's probably linked into sort of societal pressure, women's pressure. You know, that's what you should be doing, but it's just being aware of various different risk factors. 2 or more children. Kind of think these women, when they come in, that they can do it all, can't they? They've chosen to be there, or maybe they haven't, and you're making that assumption. But you kind of, you know, this is a risk factor in people being able to cope. We talk about the perfect storm and the sort of trio, the toxic trio. So previous mental illness, and I've alluded to that being a significant risk factor. If you've got substance misuse in either parent, and if there's domestic violence and abuse, then there's a significantly increased risk of PNMI. So why is it important that we pick it up? What's the impact? And we'll go through the different groups involved. So for the mother, a significant emotional distress, which is probably the thing we think about. It's actually increased risk of adverse pregnancy outcomes, probably linked to increased cortisol, and also the fact that they're probably not looking after themselves and engaging with services as well. There is an increased risk of future mental illness if you've had a mental illness around this period. It is the highest ever lifetime risk of psychosis for a woman. And then we always think about, don't we, the serious risk of injury or suicide risk and the risk of death from it. This just illustrates what I've been talking about, so you've got the antenatal period, birth, and then you've got the postnatal period. So within the first week is the highest incidence of puerperal psychosis. It tends to be a much more rapid onset, much more severe than at any other times that it's coming on. So if you're seeing this developing in general practice, it develops over days. And I've had a couple through my career so far. It's getting the perinatal mental health team involved, you know, immediately. And families and partners will generally be coming in and saying, I'm really worried about her, and picking that up. The MBRACE report came out in 2022, looking at mental health, looking at pregnancy-related deaths, one of the area of it. And really strikingly, I thought almost a quarter of women who died between 6 weeks and 1 year after pregnancy died from a mental health related cause. So we think about all the physical health. So you've got that in the purple part of your pie chart, but nearly a quarter of women was a mental health related cause, and 1 in 7 of those women died by suicide. For the child, and this I found really, I guess, eye-opening. It's thinking about the impact of the poor perinatal mental health that they will be exposed to, and the outcome of that on their neurodevelopmental areas. So there's an increased risk of anxiety and depression in the child, neurodivergent conditions, personality disorders, impaired cognitive function. And it goes down another generation as well. So there's an increased risk of schizophrenia in the offspring, so the grandchildren of that woman or that family that was affected. So the impact of these illnesses goes down generations, and makes it even more important for us to pick up and treat appropriately. The partner. So I alluded to, 1 in 10. So you've got if the woman is affected, the partner is 50% more likely to experience postnatal depression. And when I had a discussion, I did this teaching to our nurses in practice, and we were talking about them doing checks and seeing women. And actually, we don't really call, if a dad comes in and has depression, we don't really call it postnatal depression, do we? But we should do. They've got postnatal depression, and that's what's happening. And there's multiple factors that are going on, new challenges, extra responsibilities, let alone the lack of sleep, and a major role change, with their partner. And it's recognizing these feelings, and they may experience sort of fear, confusion, physical symptoms. They may be in to see you with, you know, diarrhea, tummy upset, but not vocalizing that this actually is stemming from a mental health basis. The impact of untreated PNMI on society is estimated to be 8 billion a year. It's massive. And of that 8 billion, 72% is going on costs towards the child. So the impacts of those conditions that we looked at to support the child. And the most important thing, and this is where it's really important that we can make a difference, is that if we get early intervention, if it's effective and it reduces the impact of that mental health illness on that family, then 90% of families can actually be supported through primary care with this, let alone getting the right support, you know, through secondary care as well. So it can be done. But we're not picking it up. So barriers to detecting the mental health we'll go on to. But we talk about the hidden half. So at the moment, we are only picking up 40 to 50% of perinatal depression and mental health problems. Of those 50%, only 50% are receiving adequate treatment. So could you imagine if we only picked up 50% of lung cancers and we only treated 50% of them appropriately? There would be many more targets flying around, I suspect, which is why we're trying to raise the awareness and also help destigmatize mental illnesses for these women, which still carries a big stigma. So this is moving on to have a look at, well, what's going on? Why are we not picking up these women? Because if we can have a little look at that side of it, then it should hopefully help us in our practice. So for the mother, and these are all quotes that would have been taken through from some studies through Health Watch that's been done locally sort of around us. And these are quotes from women who were interviewed. So mums were saying, you know, will they take my baby away from me? You know, I can't tell the doctor this is what I'm feeling like, because that means that I'm a bad mum. I'm not that sort of person. I don't need those antidepressants. What will my partner think of me? What will my friends think of me? Everyone else seems to be doing fine. And are these sort of quotes that probably can resonate with you if you talk to women like this. And that is that fear and the stigma that is attached to it. There is lots of cultural and health beliefs around it, and a lack of knowledge in the general population about how serious these conditions are and how common they are. And we'll come on to all the different conditions and how common they are. And then I just wanted to have a look at, well, for us as clinicians, why are we not picking up this more? So for the clinician, for us as clinicians, lack of training and support, which is what we're trying to have a look at. Time constraints, I think, is a massive thing. How often do you sit there in a consultation and think, oh, I really should ask this question, but if I ask this question, how much of a can of worms am I going to open up, and what's this going to look like? So it's just being aware of how we can help women, and I'll give you some services and things to signpost to, but we are so ideally placed to support these families in primary care and to provide that continuity and that support that they need, that it's a really important thing just to think about. 1 in 5 women reported that they were not asked about their emotional mental well-being through their antenatal care and in their postnatal check. And it's a vital part of all these checks, but women aren't realizing sometimes that they're being asked, and quite often it's about the language that we use about it. The quote on the top left: the doctor was too quick to reassure me that it was normal. I didn't share the extent of my distress and intrusive thoughts. So just really think when you're talking to these women, and just think about the language you're using. What does the word normal mean? And I'd encourage you not to think about not using the word normal. It's really common that you're feeling like this. So instead of normal, think about using the word common. It's really common. So it's making women feel that it's not just them, but actually a lot of the thoughts you're having aren't normal, and we need to help you with this. And that can really change what women will say to you. And the
Jenny,
system.
may I ask a question?
Yeah, please.
So within our postnatal check, our 6 or 8 week check,
Yep.
at least in the autoconsultation that I wrote, it's got please ask about mental health. If you ask people directly, are they likely to volunteer it? Because I'm just wondering, because sometimes it's usually if there's pre-existing, they might do it. But I just wonder that I maybe have one person in every 10 say, actually, no, things aren't going so well. But that's of course less than you would
You would
expect
expect it
Yeah.
to be.
Just wondering, are people forthright with actually how they're really doing?
I think it's all about building up that rapport to start with. And yeah, if you ask that right at the beginning, you're probably not going to get the same answer as a little bit later on through the consultation. So I think it's probably judging it. I think we shy away from asking it directly though. And I think that doesn't help. But so I guess, it's probably keeping it open to start with, how are you getting on? Are you really okay? Actually, how are you with your mental health? And that doesn't roll off the tongue, does it, quite as easily? Because we don't even like sometimes just saying that word, sort of mental health, with it. So a lot of women actually really value, as you said, James, actually that direct question of actually how are you? But I think it has to just be placed at the right time within, and it depends whether you know that woman and that family already, doesn't it? As to how easily that will follow. But you're right, if they've got a previous diagnosis, then it probably comes up easier, doesn't it? But if it's new, then it's slightly harder.
And that's the real challenge, from a practical consultation point of view, because the person doing the perinatal check may not know the patient, and they may not have seen anybody at all up to that point. So the rapport is difficult. And when you've got a single appointment to cover that and all the other stuff you have to do in this, is real challenging. So I think I certainly I'd be looking at maybe extending that to allow a proper conversation.
So part of what we've looked at, and actually we did, with the whole day session we had a whole session on the 6 to 8 week check. So I guess it's just think about in your practices how that's set up. So do you look at which GP that family has known and book them in with that GP? And again, this is the system, isn't it? And an ideal system as opposed to what we've got to work with at the moment. Do you have enough time? But actually, even if you haven't got enough time, then look, just seeding that thought of, look, if you aren't feeling all right in your mental health, please come back. I want to talk to you about it, and it's important. And that's sometimes enough for them to be able to think, well, actually, yeah, I'll go back and see her in a couple of weeks and check in on them. And also, when looking at how you set up your 6 to 8 week checks, do you do your baby check with your mum check? Quite often practices do, for logistic reasons. But actually, a lot of women said they find it really hard to then look after a child and talk about their mental health. So in your letter inviting women to that check, do you say, if you would like to bring someone else with you to look after the baby while you have your check, then please, that is something that we would like you to consider. And just, there's a few things that you maybe can tweak to help you with some of those logistics. But I do it. I'm there doing the day job like you guys. It's difficult, isn't it? And what we ideally would design is not maybe what we've got at the moment. And I guess that comes into some of these things on this slide about, funding, continuity, sort of time pressures. And it's not just sitting sort of, and I know we've got lots of other healthcare professionals sort of here today, with through midwifery, a lot of women aren't seeing the same midwife all the way through with it. And it's looking at how we can help women the best with what we've got sort of at the moment. And some of you might not quite know how your systems work in practice. So go away from this and maybe think, well, actually, can I find out, how are those checks booked in, and how could we do this a bit differently? And society doesn't help with any of this. So the social media portrayal of having this is the blessed time in your life. It's the most natural thing. Women have been doing this for years, and families. So why would you have a problem with it? You've got it all. You have your baby now, and you've had that ultimate fulfillment. And those pictures on Instagram of, you know, back exercising, you've got your tummy back within 6 weeks, and that pressure that then really is put on women, that no one else is feeling this. But how many times, you know, do we put posts on saying, I'm really struggling today? And that goes through all sorts. It's not just perinatal mental illnesses, it goes through everything in life, doesn't it, of what people post and then the ultimate reality. So that's maybe some of the pressures and where we're sort of not helping ourselves and families the most. So looking at the prevalence, and we'll come on to the conditions. So it's really common. So this is per 1,000 maternities in England. So most common at the bottom. So the most common is adjustment disorders. And then coming on to mild and moderate depression and anxiety, severe depression, PTSD, and then 2 in 1,000 will get a postpartum psychosis, and 2 will have a serious mental illnesses, chronic mental illness with it. So it's common, and that's why we need to be picking it up more. So looking at adjustment disorders, there's the DSM-5 definition there, that it's the development of an emotional or behavioural symptoms in response to a stressor occurring within 3 months, and that's evidenced by marked distress. And again, the societal pressures, you know, every woman falls in love with their baby instantly, don't they? Well, they don't. Only 40% of new mums, when they were surveyed, said they fell in love with their baby straight away. So there's a lot of adjustment disorders happening, which is what we can see sort of from the figures. So it's asking women and picking it up and supporting them. Moving on to depression. So the next most common. What does it look like? It looked like depression at a lot of other times in people's lives, but there's probably a few key things just to pick out. And one question I really like picking up, lots of different perinatal mental health problems, is can you sleep when your baby is sleeping? It's a very different question to how much sleep are you getting? And women will be fed up of people asking them how much sleep they're getting when they've got a newborn baby, and please just don't ask it. But can you go to sleep when your baby is asleep? Because if you can't, then that means your brain is on overdrive and you can't switch off, and those cortisol levels and that serotonin is going round and round and round in there. So think about asking that question. I find it really useful. But a lot of the other things will be very similar to when you other questions you ask for depression. So does she present like this, or does she come in like this? Absolutely fine. You never quite ask that question, and you never get to the bottom of what's going on, really. And there's a big campaign of look behind the smile, ask those questions. And really find out what's going on. So anxiety, and as we saw before, anxiety is so common. And going through doing this learning, I realised actually a lot of the women that I was probably thinking were tipping into depression actually probably just had really bad postnatal anxiety. And again, can you sleep when your baby's sleeping? They quite often come in for very frequent consultations. Now, that probably isn't going to be about themselves. It might be about themselves. It's probably about their babies. And this is where having that sort of being that detective and that spidery instinct of what's going on and having a look. So have they been in with your nurse practitioner quite a lot, looking at baby? Have a little look in the records, and we're well placed in sort of general practice to be able to look at what's going on. And they may not come in with complaining of mental health problems, but actually they may be coming in with frequent physical problems. So again, it's just thinking about, is this cause of these physical problems, so the chest pain, abdominal pain, really, are we looking at a mental health cause of it? Or does she come in and look exactly like this, and smiling away, perfectly made up, dressed there with her baby, with everything as it should be? Perinatal OCD is another area that I probably knew less about. And within this, it's the intense feelings of guilt, but also how common thoughts of harming their baby is. And if you don't ask women about this, they won't tell you, and they will go away still feeling that they are a terrible mother because they've had thoughts of harming their baby. COVID hasn't helped with OCD, so repeated bottle washing is improving, but the whole hygiene and fear of viruses and illnesses is still around. So, or does she look like this? But the most, I think the most important thing I'd like to take away from OCD is that 100% of new mums will have thoughts about accidental harm of their babies, if you've ever asked them. And if you don't ask them, they won't tell you. So what happens if I just let go of this pram and it rolls into the road? Or if I trip up when I am carrying my baby, that might harm my baby. And those are, that's 100% of new mums. And if any of you are mums, then I hope you can identify with some of this. But probably no healthcare professionals ever asked you about that. No one asked me about it. And I remember thinking, I'm walking down the stairs with my baby. How can I do this? What if I trip up? And I sometimes do. That's normal, isn't it? And you just think about it. But it's reassuring them that that is completely normal. 100% of women have that. But the important thing is then following the size of these circles down. So still, that's accidental harm. Women then do have thoughts, more than 50%, of actually causing deliberate harm. Oh my goodness, will you just stop crying for me? And those thoughts, they won't have any plans to act on them, but that thought goes through their mind. And a lot of women find that really distressing and feel that they shouldn't even think that, and that is completely wrong, that they've even thought about that. Only 3%, so we're getting much smaller in our circles, have repeated thoughts of harm that interfere with their life. But that's 3 in 100 women, and that's interfering with their life. And then we get right down to the really small circle that is less than 1% of new mums will actually act on thoughts of harm to their baby. So we're right down, the risk, but they're obviously the high risk that we need to pick up. But don't be afraid in asking. Perinatal PTSD. So how do you ask about what a woman's delivery was like? Just think about, so do you look at the notes before? Do you use the word normal delivery? And I'd encourage you to get rid of the word normal out of that. Again, like we talked about before, that's passing judgment on what happened there. It's not a normal delivery, it's a vaginal delivery that you've had. Or have you had a cesarean, and having a look at that. And we might look at it as healthcare professionals and say, oh my goodness, you've had a horrific delivery. Or, oh, it looks like it was, that was a straightforward vaginal delivery, wasn't it? But to that woman, that might have been the most traumatic thing she's been through, or for the partner, seeing her go through it. And PTSD is really common, reliving that labour and that sort of playback in sort of nightmares, with it going on. Sometimes this doesn't come out until quite late on as well. It might be when she's thinking about having another child and suddenly that realizes where these feelings are all coming from. And every maternity unit, so every delivery suite will have a listening service, and they will go through the notes and take a woman through actually the journey of what happened during that delivery to help her go through it. And that's a really good thing. I'll come on to that in resources. Or does she not tell you any of this and leave smiling, and you're none the wiser? Postpartum psychosis, which is one of what we all think when we've looked at done education that we don't want to miss, and it really is. It's bizarre behaviour, poor bond, absent or estranged from the baby. It's a rapid deterioration, as I said, in that postnatal period. Or does she keep it together for a while and then things gradually unravel? So that was a quick overview, and there's quite a variety of conditions that I think sometimes we forget about. It's not just your postpartum psychoses and your depressions, but there's quite a variety of mental health problems that women have. So I don't know if there's any questions about the conditions at all, James, before I go on to a few bits.
Not on the chat in the moment, but people, if you'd like to put any questions, please pop them in there and we can bring them to Jenny later on.
Perfect. So how can we support patients with PNMI? And the most important thing is time and a safe space to talk to, preferably someone they know, a healthcare professional that they have got a previous relationship with. And that's something that we can do in general practice if we look at our systems. Check support and safety nets at home. So how are women supported? But also, don't, if they do have a lot of family support around, sometimes that equally can be a little bit over a bit suffocating in a way as well. So if they've got too many family around, then they recognize with them that might be too much as well. Please, we'll come on to prescribing. Don't automatically stop existing medications when someone becomes pregnant or is breastfeeding. We feel like we don't want to be prescribing because we don't want to cause harm, but actually stopping those medications is likely to cause more harm than continuing them. And when you talk to perinatal psychiatrists, then they keep most medications going, and we'll come on to some resources and things to help you, but they are very happy to give you advice, and as part of this work I've met with the perinatal team, and they run clinics for prenatal counselling. So any women that you want advice for, and that's why I was saying, think about it early. So anyone who's had severe depression or is on a medication, then think about it early if they're planning, if they come to you, or when you're doing their annual depression review, then actually, if they're of childbearing age, are you considering a family in the future? And if you are, please just come and talk to me about your medication before you get pregnant, and we can have a chat about it. It's just planting those thoughts and those seeds sort of there. As we talked about, one of the risk factors for this is unplanned pregnancies. And please don't forget to talk about postnatal contraception. And that may be the one thing that helps that woman in that postnatal check. If she knows that she's not going to get in the same position again at the moment, she may be able to cope. So sometimes, I know we all think about it as part of that check, but just remember to do it. Think about your PNMIs in your frequent attenders, so other members of the family as well. So have a look in their records, see what's going on, and have a look. If a patient has bipolar, then they should be referred early. They should be under psychiatry to have a formalised, personalised care plan. And remember that, harm does happen, and that's why we have to think about it. But it's rare, and safeguarding is a rare issue with it, but we also need to think about it. So, as I said before, so look behind that smile. Think about setting some time to talk to mum. Maybe if that's separate from baby. And actually, I think this is something where doing some work by telephone still is helpful, because you can set up, that depends what structure you're all working in sort of now, but you can actually set it up. So would you like to come in without your baby? Well, when would that be a good time for you? And giving them the option. Use your communication skills. So look, listen, wait for those pauses and that continuity with it, and avoid normalizing. It's common, but it's not normal that they're going through this. A few questions just to have a think about if this helps you within any of your consultations. And I've been through some of them. So nice open questions. Tell me about your birth. How are you finding being a mum? No judgment there. They can feel open to answer that. But as I talked about with sort of James a little bit earlier on, don't be afraid to ask those questions though. So have you had any new feelings or thoughts that make you feel disturbed or anxious? Are you experiencing thoughts of suicide or harming yourself? So obviously within the right context, within the consultation, and maybe giving them a signpost of that. But don't be afraid to ask. And women who are feeling it are so pleased you've asked, because they can answer it, rather than if you don't ask, they'll go away without telling you about that. We talk about, if there is a disclosure made, it is a red flag. So if a woman tells you she is struggling, then please take that as a red flag warning that we need to help this woman and this family. So get support from your general practice team, your health visitors, depending on which role you're in, and the perinatal mental health team is there. So just going on to think about what we need to do for these women. So think about a risk funnel. So at the top, you've got the majority of women, so more of them, that they're doing okay all in all, that they may need just a bit of support, but they're going to do okay. We don't need to do that much for them. Then you come down your risk model, getting narrower, less people affected, that things aren't going quite so well, that feeling quite down, I'm not a risk to myself at the moment. And then we go further down, that actually I'm not going to act on those. And then we get down to the bottom, whereas actually I don't think I can keep myself or my baby safe. And that's where we've got the perinatal mental health teams. And then you've got the speed of how quickly you need to talk to them. I'm just going to do this in slightly different order. So you've got on this slide, you've got, this is so you've got a structured form for referral, and you email it over to the perinatal mental health team, or there's the telephone number if they answer yes to any of the red flag questions. So any perinatal red flag postpartum, if they've a significant change in their mental state, if they have new thoughts of or acts of self-harm, if they have new and persistent expressions of incompetency as a mother or estrangements from the infant, they want you to phone them and speak to them about it. But there are lots of other services available. So NHS talking therapies, and your perinatal mental health team, and when I met with them, it was really interesting, and actually they're doing things that other areas aren't. So don't worry too much where you signpost a woman to, whether you do a perinatal mental health referral, or if you tell them to called NHS talking therapies, because they actually have a regular meeting, and people that they think are best suited in either service, they will switch them around. So if NHS talking therapies thinks they're a bit too complicated, they'll move them over to the perinatal mental health team, and vice versa, they'll switch them around if they need to. And NHS talking therapies prioritize families, women, partners who have access their service, and they're aiming to give them support within 2 weeks of them contacting them, but they need to tell them that they are in the postnatal period or in their perinatal period for them to be able to prioritize that, and that's a target for them, and that's they're really working towards that. You have a new website for perinatal mental health in Nottinghamshire now. I don't know whether that has been cascaded to you at all. It was, I'm seeing James shaking his head. It went live a month ago, and Lisa, who's the service manager at the perinatal mental health team, let me know about it. And it's a great resource for healthcare professionals, and also for families. So it goes through what the service is, throws through who should be referred, and it's also got sections that they're building on about how we can support women. So they're building in the voluntary sector as well. And as part of the work I've been doing, and James put me in contact with her, I've got a fellow who is taking some of this work forward. So she's looking to build on the resources that you've got locally to make sure it's all in this one place, and looking at getting integrated into your computer systems as well, on your, is it F11, F12 that you use within that, and look at getting those. So when a woman says I need some help, you actually can say, well, actually there is this peer support service you could access, there's this baby group you could go to, there's this young mum service, or go and have a look on this website, it's all on there, have a look at it, and we can have a chat through it so that you've got the resources. So if you just Google it, that Nottingham perinatal mental health service website is live at the moment. This is what Kelly is looking at sort of developing. This isn't in your area at the moment. This is what we have in Coventry and Warwickshire. And it's a traffic light system of all those different services that are available. So think about categorizing women into green, amber and red. And actually, if I've got a woman who is in the green area, what services have I got that I can use for her? And that's what we're looking at developing. So one of my colleagues who did a lot of this work in our area sort of 3 to 4 years ago set this up. And that's what Kelly's looking at, sort of trying to develop in Nottingham. So you've got more resources that you can use for women, because they are out there. They're just not all in one place that you can easily access to know how to help women. So prescribing in this period, please, as I said, don't stop medication. Don't have a knee-jerk reaction that I'm doing more harm prescribing this than I would be stopping it, because stopping medications has a consequence. So think about, is this medication safe in pregnancy? And when you're thinking that, you're really weighing up, do the benefits of this medication during pregnancy outweigh the risks for this particular individual? And that's why it's really hard to say that this is what you should always use. This is what you should, that's not the answer you're about to get from me, because it so depends on that individual situation. So a woman may have tried every antidepressant there is, and she's well on this one. It may not be the ideal lowest risk one in pregnancy, but she is well, and that's going to be much better for her developing fetus, and for her ongoing health, and for to be able to look after that baby. So it is difficult. We recognise it. You want to choose the drug, if you can do, with the lowest risk profile. And this is why it's worth thinking about this even before a woman gets pregnant, if you are of childbearing age, actually, are you on the lowest risk medication? Generally, you want to be looking at an SSRI, and sort of sertraline is probably your lowest risk. But for that woman, it may not work. So she needs to be well with it. And then the other principles to think about. So you've tried to think about the one with the lowest risk profile. You then want to use the lowest effective dose of that medication, but it needs to be an effective dose. There's no point just cutting it down so that she's only having 5 of some, or 10 of, something, and it doesn't work. You're worse off. So it needs to work. Ideally, to be using a single drug, and speak to your psychiatrist. They're very happy to give you advice about it. Resources, if you haven't come across them for prescribing, so there's the Bumps website, so Medicines in Pregnancy, and that is written for patients. So I quite often go through that with women, send them the page that's got their medication on it. They can have a look at it, and then we can talk about it again in a few days. And UKTIS is the healthcare professionals side of that, and it lists all the studies there is. And as we all know, there isn't a lot of evidence there. It is mostly because really ethically to do those trials in women and on fetuses is not ethical. So it's case studies and it's evidence built up over years of prescribing that we have. There is more evidence than you think. The BNF, when you look at it, just says advise avoid, so doesn't really help you. So have a look at these other websites and they're really useful to look at with women. So what's the prognosis for PNMI? And it does depend on the type and the severity and the support that's in place. But if we pick up these women earlier and these families, and if we have a positive approach to treating them, and that they know that we can treat them and get that support in there, then we can treat, as we said sort of to start with, over 90% of women in primary care and get help for everyone else. So please think about looking behind the smile, that it's every woman every time. So you may be seeing her about a child, just think, that family, trust your instincts. If they're coming in time and time again and you don't know what's going on and why they're bringing that baby in, because that baby looks really well to you, then there's something else going on. So ask that question, be aware of bipolar, and ask for help. There's help around, there's support around there. There's a few books on here, and you can have a look at it from the resources that you may want to, if you're interested yourself, to have a look. Or I sometimes use these with my patients as well. One I particularly like is Anna Mather's Mind Over Mother. It's looking particularly at anxiety. As part of this work, we've recorded some podcasts as well, which will go up on our website, and I can send them round when they're live to you. And there's a podcast with Anna Mather talking about her work and her book. What Have I Done is about postpartum psychosis. It's really insightful, quite a difficult read, but makes you realise from a patient's perspective what it's like to go through. So what can we do differently? So we're looking at training all staff within practice to recognise these soft markers, because it may not be that it's you that they're seeing every time. Please just have a think about your 6 to 8 week mother and baby check process. Could it be done a bit better? Don't forget that contraception. And encourage having that conversation about mental health in new parents. Please start treatment if you need to. Don't shy away from prescribing, but signpost to relevant support services early. So don't wait until things really do become a crisis. Get that support in to help those families. And refer into the perinatal mental health team in a timely fashion. And what they would say is, please just give them all the information that you've got. So a detailed referral letter, and they can then triage that appropriately. So not I think this woman has got postnatal depression, but why do you think that is? What's their family set up? What's going on? What symptoms is she coming? How have you picked it up? And what can they help you with? Would be really useful to them. So that is all that's the slides I've got to go through. There's a QR code just on there. If you could just scan that and just give us your information, that would be really good. And I'm more than happy to take any questions and answer any questions.
Wonderful. Thank you so much, Jenny. That was really interesting. I learned loads there, particularly about PTSD in post-pregnancy, which is not something I really thought about. I mean, if you think about it, it's logical, isn't it? But it's just trying to kind of incorporate that into our consultation. So right, a little question. So there was a little discussion there, I mean, admittedly between Anna and myself, about what work is being done, and what would be best practice in terms of what happens before they get to us. Because I think quite a lot of the time it feels that people aren't necessarily aware of what to be looking for or what to expect. So what can we do to try and help support teams before that? So I'm guessing health visitors and midwives to really tee people up for this.
Yeah, so actually I'm not sure, have we got any health visitors or midwives on the call now? I can't remember whether there was a couple signed up. There was a midwife on the list, actually. Maybe they're not here.
I was just going to say, I'm doing a postnatal pregnancy and postnatal yoga course at the moment, and there's a couple of midwives doing the same course. And when that has come up, they've said they've got so many things that they have to run through already in their time that anything else is just, a bit too much. So there just really needs to be more services available beforehand. There's no other.
And I think that's the problem, isn't it? Is that Anna talking at the moment there?
Yeah, it is.
Yeah. There is so much to do, isn't there? That I think this gets sort of not forgotten. It's just probably gets pushed to the bottom of the pile. Whereas, checking the urine pressure and things is what. So just raising awareness. So the perinatal mental health team have actually done quite a lot of teaching with midwives and health visitors sort of recently. So educating sort of GPs in primary care was on their to-do list. So she was delighted when I turned up. And so I think it's just raising the awareness, but equally for them, they need to know the resources, don't they, to be able to use, because again, they're asking that question. And then you then have to be able to respond to it. Yeah. It's challenging, isn't it? But there is work going on, and that's one education area that they have prioritized at the moment.
I think from what you've been saying, a lot of it's about sort of raising the profile of this as a condition within the sort of pregnancy sort of oeuvre. Because I mean, we think about all that other stuff, early pregnancy bleeding, abdominal pain, hypertension, preeclampsia. Speak to most GPs, and that'll be high up on the list of things that they will be thinking about and do not want to happen during the pregnancy. But actually, the depression aspect of things, which we deal with all the time in lots of other respects, doesn't necessarily float to the top. But I think that I agree with Anna and with yourself that earlier kind of mentioning and intervention and helping coach patients is vital, because by the time they get to us, things might be quite far down the line. And in terms of time, in our postnatal check, we're looking at looking at a scar and blood pressure and,
well, you've got so many things, haven't you?
Yeah. And feeding and sleep, and so I think there needs to be like little, just even little inputs. I think could make a big difference, don't they?
Yeah, absolutely. I think you're so right. It's raising the awareness and raising the awareness to patients that this might happen. And I think if you put a comment in there, Anna, antenatal classes, although no, there's not much going on at the moment, but even if they just said in antenatal classes, look, this is what, you may have problems. It's, we can help you. It's common. And it just makes women realize that actually they aren't on their own, and that this is recognized. And that's what all of this about, because none of what I said is really hard medicine to do. It's communication skills, getting the right resources involved. Some of it is time dependent, but we can follow these women up. We're going to be seeing them. We know their families. And that's where we can help in general practice.
Yeah. I will say as well that I'm a social prescriber, and we don't get many pregnant people or postnatal people through to the service, and there's no reason why not. And we've got more time to spend with people, and then we can signpost them into places where they can get a bit more support. So I mean, the time frame thing's still an issue because we've got a waiting list, but to think about referring pregnant and postnatal people through to social prescribing as well.
And that's brilliant, Anna. It's great to have you here, sort of with that different role. And I guess it's how practices are then moving on and using sort of those different roles. And I don't know within your practices or how you structure it. Actually, have you got a particular interest sort of in this, and are your practices aware sort of that it's
a new emerging interest. It's a complete new career for me. I've been doing it since August, but I've noticed that we're not getting pregnant people coming through, and I'm already a yoga teacher, so I've trained now. I'm finishing my training in pregnancy and postnatal. So, and then now we're going to focus on making midwives and practices aware that that we've got an interest in that, and hopefully get some more people through. Because also I went to a talking therapies conference a couple of weeks ago, and people aren't getting signposted to that as well, pregnant, postnatal. So I think there's a lot of work to be done across the board to make sure that services are reaching this demographic.
And especially when the traditional ones, such as antenatal classes, are perhaps not as prevalent as they once were. More important than ever to actually link people into what is available and charity,
use what we've got
and all of that sort of stuff. So it's not something I thought, so it's really great to have that input. Thank you very much, Anna.
Yeah, absolutely. Anna, I think I was just looking at your comments. So yes, the slides I've sent through, so you can have those. Apologies, did I say 2 years at one point postnatally?
I couldn't remember if it was a year or 2 years.
It's up to a year. Yeah. It's up to the first birthday. Yeah. So effectively, you get to nearly a 2-year period. So you've got 9 months antenatally, and you've got the year postnatally. Yeah.
Brilliant. Any other questions? We've got the last couple of minutes before we finish off today. Okay. Well, I mean, we finished bang on time there, Jenny. That was very impressive. Thank you very, very much. It's been a really fascinating talk. I've learned a huge amount, and it's really great to hear the work that's going on and trying to educate others. Now, I'm not sure if we'll be able to get a chance to do any others of these. With any luck, we can. But if not, this will be up on YouTube. So if you've got any colleagues that have missed this fantastic talk, please direct them towards YouTube, and that should be on in the coming sort of weeks. For you to have a look, and of course we've got the slides there as well. As I mentioned, we're hopefully going to do an obstetric and pediatrics sort of study day, and that's likely going to be like June. So keep your eyes peeled for that, and we'll hopefully get Jenny back for that if we can. And just get like a really good lot of topics in to support our pregnant people, young babies, children, and that whole sort of area of life. So hopefully keep your eyes out for that. As I said, we've got the dermatology camp soon. It's been a pleasure. Thanks so much for your time today, this lunchtime. We hope to see you at another event really, really soon. Please make sure you do Jenny's feedback, and also if I can ask if everybody could do our feedback as well, that'd be really useful so we can bring you more events that you might enjoy. Thank you very much. Jenny, if you've got any closing words.
No, thank you for having me. And please, if there's anything you need, then please just let me know. Yeah, thank you.